Hello, everyone, and welcome back. I'm Rahul Gosain here with my brother and co host, Rohit Gosain, on our podcast, The Oncology Brothers. Our focus continues to be on bridging the gap between academic research and community practice, as majority of our cancer patients today get treatment in these community settings. Today, we're going to touch on one of the most aggressive cancers we come across in our day to day clinical practice: acute myeloid leukemia, AML. To walk us through the current standard of care for this disease, we're grateful to be joined by Dr. Anand Patel, a hematologist and the medical director of Inpatient Leukemia Service.
Thanks so much for having me. I'm really looking forward to this and being able to talk through AML, both the diagnosis and what to do if and when we need to think about other therapies.
Awesome, Anand. Thanks so much for joining us. Let's dive right in. So, being the medical director of Leukemia Service there at University of Chicago, this won't be an uncommon scenario where you would receive a call from the community oncologist, where a patient with high peripheral blast count and ongoing B symptoms, where the worry is that the patient has, in fact, AML. Today, in 2025, when you see these patients, what's your minimal workup to diagnose and, importantly, also to risk stratify these patients?
I'm going to talk about this in two phases. The first is the phone call, so you hear about a patient where there's a suspicion of acute leukemia and maybe acute myeloid leukemia. The things I run through with the oncologist or hematologist that I'm discussing the patient with as we're kind of getting ready for a transfer is why are we worried? Is it circulating blasts? Is it pancytopenia, NOS? B, is there any concern for acute promyelocytic leukemia? Well, I like to think of APL kind of like appendicitis. There used to be this thing where if you're not doing an appendectomy in someone who doesn't need it, you're probably not catching up appendicitis. So same way, if you're not giving Atra to a couple patients that may not end up having APL, you're probably not thinking about acute promyelocytic leukemia enough. So that discussion of is there concern for APL? Is there access to Atra at the outside hospital? If there is, and can we get a dose in that patient while we're arranging for transfer? And then I think the third thing I think about is the white count, how high it is, if there are any clinical signs or symptoms of leukostasis, and if cytoreduction needs to be initiated versus something more aggressive, and whether that can be done at the hospital that the patient is currently at versus needing to wait until they arrive. I will say, being at the University of Chicago, oftentimes we have frontline clinical trials for patients, and I'd say standard therapies are effective in AML, but we have a long way to go. Our preferred approach is from a clinical trial standpoint. Oftentimes we will perform a bone marrow biopsy once a patient arrives. In general, if there's suspicion for acute leukemia, but the patient is otherwise stable, I wouldn't say there's a ton of urgency to performing a bone marrow biopsy prior to transfer. I'd say really, if it's pancytopenia NOS, where you're not really worried about acute leukemia, or you don't know why someone's counts are low, getting a marrow and getting a sense of where you're heading diagnostically helps. Oftentimes, a bone marrow biopsy may need to be repeated for a patient interested in a clinical trial. Upon a patient arriving and when they get to us, I'd say the minimum diagnostic workup would be, of course, a bone marrow biopsy with flow cytometry, not just conventional karyotype, but also FISH studies. The relevant FISH studies are core binding factor, so inversion 16 and translocation 81, and now presence of the KMT2A rearrangement because we have therapeutic options there.
Indeed.
So FISH studies, typically come back in 48 to 72 hours. Conventional karyotype can take up to a week or longer, depending on where you're sending it. And then we'll send a broad molecular panel. Our current risk stratification for AML has several genes incorporated into it. There's really two risk stratifications that we think about. There's the ELN22, which is mainly focused on patients receiving intensive chemotherapy upfront. And then there's the ELN24, which has been devised for patients who are treated with lesser intensity therapies. It's not just, the actionable targeted genes that are worth interrogating, NPM1, FLT3, IDH1, IDH2. Really getting a broad molecular panel that allows for appropriate risk stratification is critical. Not only in the initial setting, is this patient going to benefit from intensive chemotherapy versus a lower intensity approach? Down the road, that oftentimes influences how we consolidate a patient. Is it going to be with chemotherapy alone, or should we be thinking about allotransplant?
And again, on the theme of broad molecular profiling for our audience, can this be done on peripheral blood if you have high blast count, or should this only be done on the bone marrow sample once the patient's been transferred?
Great questions. If someone has greater than 5% blasts circulating in the blood, I think it's very appropriate to send off the peripheral blood for the relevant studies. You could even do that for FISH along with the molecular studies. it's a little tougher to be certain if someone has just rare blasts in the blood or something like that. And then typically at time of bone marrow biopsy, it's probably worth repeating molecular studies from the biopsy sample itself.
Perfect. And you touched on this risk stratification. The idea here is twofold. One, you're using this to guide your treatment, but the outcomes also differ. But outside clinical trials, in a patient who can tolerate induction chemotherapy, we're still relying on 7+3 chemo upfront or CPX 351. This is often reserved for therapy-related AML. But with this, we have to worry about prolonged cytopenias and financial toxicity. But after initial intensive chemotherapy, what next? Who gets that targeted therapy for how long? Can you walk us through your treatment paradigm here?
Yeah, so kind of thinking about the intensive bucket. If someone has favorable risk disease, our goal is to really try and cure this AML with chemotherapy alone. So typically that will be utilization of a 7+3 type regimen. For core binding factor, oftentimes gemtuzumab is added to that 7+3 backbone. And then if someone has a FLT3 mutation, a relevant FLT3 inhibitor can be added. In general, it's only really the FLT3 TKDs that would still fall potentially into a favorable risk bucket. The ITDs will be intermediate at most. And then you move to a cytarabine-based consolidation, somewhere in the neighborhood of 3 to 4 cycles. Oftentimes you include the targeted agent utilized with induction. One kind of pearl about consolidation is that there was a new study in the New England Journal of Medicine Evidence that looked at the dose of cytarabine, and less is probably enough. So 1.5 grams per meter squared of cytarabine is just as good as 3 grams per meter squared. So I think that's very relevant, particularly if patients are transitioning to native therapy, not at the same center where they receive their induction. For intermediate and high risk disease, really the paradigm becomes induce a remission and try to get to allo transplant if someone is an appropriate candidate for allo transplant. So again, we kind of go back to utilizing the intensive chemotherapy, whether it's 7+3 or whether it's CPX 351 for the relevant patients, have the transplant process that's undergoing or underway, and then ultimately trying to move forward with an allo transplant. I will say in general, patients usually get at least 1 cycle of consolidation after induction. It's not common for patients to go directly from their induction cycle to allo transplant. Let's say a patient who you initially treat intensively, they're receiving consolidation, and for one reason or another, they aren't able to get to an allo transplant. So then you start thinking about maintenance therapy. In that setting, we have a few different approved agents. There's oral azacitidine, CC486. And one thing to know is oral azacitidine is not bioequivalent to subcutaneous or parenteral azacitidine. The drug itself is its own thing. Don't think of it as interchangeable with IV or subcu AZA. That was based on the phase 3 Quasar study. So it's maintenance that's given indefinitely. It's continued as long as blood counts are tolerating it. Now, I will say the study that led to its approval, there is some nitpicking that can be done about it. Particularly, many patients did not receive more than 1 or 2 cycles of consolidation. So the thought is if patients get appropriate consolidation, is there any benefit to adding oral azacitidine? But it is an option that's there. And then, kind of thinking about in the FLT3 mutated patients that don't go on to receive an allogeneic transplant, there have been follow-up analyses done of both the Ratify study, which led to the approval of midostaurin, and the Quantum First study that led to the approval of quizartinib, that showed that the role of maintenance is very unclear with midostaurin and perhaps a little stronger with quizartinib. The FDA labels actually reflect that as well. So using the relevant FLT3 inhibitor in that space. Really, that's how I think about intensive chemotherapy and transitioning to the post-induction phase, whether it's consolidation, allo, or maintenance. I will say this is a landscape that's shifting beneath our feet. So the question is rapidly becoming not just is someone fit enough to receive intensive chemotherapy, but should they be receiving intensive chemotherapy versus HMA plus Venetoclax as an regimen. A study published in Blood earlier this year from our colleagues in China randomized patients to decitabine ven versus standard intensive chemotherapy, and this was an 18 to 59-year-old patient population. And the major bullet is outcomes were equivalent to maybe even a bit better in the HMA ven arm of therapy, particularly in intermediate and adverse risk AML, whereas favorable risk AML intensive chemotherapy still seemed to kind of hold a benefit. This is a study that primarily looked at CR rates. The follow-up for survival is still ongoing, so can't take a whole lot from there. There's a very similar study that's being done, and I believe is close to enrolled or has finished enrolling. Now we're waiting for results, led by Dr. Fati at MGH, that's looking to answer a similar question here in the United States.
Well, thanks so much for summing it all up on induction standpoint, as well as consolidation and followed by the transplant. Anand, outside of clinical trials, any role of FLT3 inhibitor as maintenance therapy after transplant? Because we know that we utilize this in induction and consolidation, but how about after transplant itself?
Yeah, outside of a clinical trial, I'd say that the two FLT3 inhibitors that probably have the most robust data are sorafenib, which can be very hard to tolerate. It has a side effect profile, rash, GI upset, those sorts of things that can make it hard for patients to tolerate. And then there's gilteritinib. So gilteritinib was actually looked at in a very well-designed study called the Morpho study that looked at the use of gilt versus placebo in patients with FLT3 mutated AML that ultimately go on to transplant. And really the takeaway from the study is that it was a negative study, but it's a little more complex than that. My takeaway from that study is if you have FLT3 detectable disease by MRD going into transplant, you will certainly benefit from having gilteritinib post-transplant as maintenance therapy. Those that have MRD going into transplant, and particularly those that have MRD detectable after transplant, it's not a question of if the disease is going to relapse, it's more of a question of when. And gilt can help eradicate that small clone that's left behind. So that's really the two FLT3 inhibitors that I would say have the most data kind of in that post-transplant setting. And I would say as a group, we tend to prefer gilteritinib when we're thinking about a FLT3 inhibitor, given its side effect profile compared to sorafenib.
And this would apply for ITD and TKD both?
That is correct.
Okay.
So gilteritinib, is
Right.
one of the inhibitors that's both.
Exactly.
So yeah, we'd be thinking about it for both.
And we will get a chance to take a deeper dive into the FLT3 story, part of our challenging cases with Dr. Uma Barade and Dr. Naval Davar. But when these patients are on maintenance therapy, they are being followed by a local team as well. And of course, we are well aware about the sorafenib side effects. Any important clinical pearls or side effects to keep in mind with other FLT3 inhibitors?
Yeah, so there is this signal for QTC prolongation, really looking at concurrent medications. Many of these FLT3 inhibitors will try to get EKGs weekly for the first 4 weeks. And then beyond that, it can be more like every 4 weeks or so. Patients who have underlying cardiac toxicity or are on diuretics, those that are at risk of having hypokalemia or hypomag, making sure that those are being adequately supplemented or repleted. That's really the other big thing I watch out for. In general, when you're using FLT3 inhibitors in the maintenance setting, you're not having to worry as much about differentiation syndrome, which can be seen in patients with bulk disease when they're started on a FLT3 inhibitor, but certainly not as relevant in that maintenance setting.
Indeed.
And again, thankfully, the incidence is low for differentiation syndrome. Anand, before we touch on patients who cannot get induction chemotherapy, quickly, you touched on gemtuzumab. We have disease-free survival with this, correct?
So gemtuzumab, the story of gemtuzumab is a very long and winding one, so I'll try to keep it brief. Gemtuzumab was evaluated in several randomized phase 3 studies that kind of took all comers with AML. Yep. And a meta-analysis of all of those studies ultimately demonstrated a survival benefit in patients who had core binding factor AML. So the 5-year overall survival is about 75% versus 55%. And those that received gemtuzumab at some sort of dosing schedule with some sort of chemotherapy backbone, lots of heterogeneity, because this is a meta-analysis of many studies, versus those that received intensive chemotherapy alone. Based on that, gemtuzumab has typically been incorporated into intensive chemotherapy. It was studied in NPM1 mutated disease where there was no overall survival benefit, but there was a DFS. On longer follow-up, that DFS has gone away as well. So we know that adding gemtuzumab to intensive chemo for NPM1 may offer deeper remission, but it's unclear whether that actually translates into disease-free or overall survival. And then the last thing I'll add is we led a large real-world analysis looking at intensive chemotherapy in core binding factor AML at various centers across the United States. At least in our analysis, we found no benefit to adding gemtuzumab to intensive chemotherapy. And I think a lot of that comes from the fact that places use gemtuzumab differently. They use different backbones. I think there's a lot to still be understood about how best to utilize gemtuzumab in core binding factor AML.
Absolutely. Okay, now let's switch gears to a patient who is not a candidate for induction chemotherapy, as these are the patients that we'll likely see in our community settings. Hypomethylating agents with Venetoclax has been well adopted. But again, you touched on this. This is still not the easiest regimen. And what about aza versus decitabine? Are they identical in terms of their outcomes? And what about the targeted agents here? Should these targeted agents be combined with azavan? Should this be used single agents? Your treatment paradigm here with someone who's not fit for induction chemotherapy?
Yeah, for the most part, azacitidine and decitabine are largely interchangeable. That being said, we still use azacitidine as our preferred backbone to add ven on, given that the BIALI-A study looked at that in a phase 3 setting. So we tend to use azacitidine in combination with venetoclax when we are using an HMA. The question of triplets versus not is a difficult one. For me personally, I would need to see robust randomized data that supports the utilization of triplets, because the trade-off ultimately becomes increased myelosuppression for
Yes.
better responses. So I think the triplet that probably has the most buzz around it is azacitidine plus venetoclax plus gilteritinib. The MD Anderson experience using that triplet has been published. And even within that experience, you can see that there was considerable dose modification that needed to be done, both to the dose of gilteritinib and venetoclax, to ultimately make it a tolerable regimen. The other thing about gilt is it seems to be the targeted agent that holds its benefit in the post-venetoclax setting. Some targeted drugs, and we can talk about this at Relapse a bit more, aren't quite as effective in someone who's venetoclax exposed. I think we have to be really cautious about incorporating triplets until we have randomized data to support their utilization versus that azaven backbone. The other thing I'll add is these are patients that you're not necessarily thinking of as being able to go on to an allo transplant.
Yep.
So if you are committing someone to a triplet, you're really committing them to a triplet maybe indefinitely. You have to figure out when you're going to drop which drug, and we don't really have any data about that. Do you get rid of the venetoclax? Do you get rid of the targeted drug? Do you just cut back on the durations of all of them? So that really makes it hard to figure out how to optimally adopt a triplet outside of a clinical trial.
Yeah, I
And
want
in
to
those
reiterate something here, actually, Rohit, that this is all anecdotal. The data that we have for triple therapy showed significant myelosuppression, and outside clinical trials, we need to be careful with that.
And whenever we're talking about indefinite therapy here, at least from leukemia standpoint, do you utilize MRD to decide whether to bring the patients off of the therapy and resume the same one if there is any chance of recurrence?
Yeah, so BIALI-A studied azacitidine venetoclax essentially indefinitely.
Right.
So as long as there was benefit and disease control, patients stayed on therapy with dose adjustments based on cytopenias, depth of cytopenias, and duration of cytopenias. Now, since BIALI-A, there have been retrospective studies, nothing prospective, that have started to look at the question of, can we figure out which patients can come off therapy? I think one thing that makes flow MRD very difficult is the data for flow MRD, I would say, are not nearly as robust for AML as they are for ALL. And there's a lot of heterogeneity in flow MRD. So then we're left with molecular targets. And I'd say the best data come from NPM1 mutated AML. So this was published last year as well. What was found was that there was a cohort of patients identified that had NPM1 mutated AML and achieved MRD negativity after at least 4 cycles of azacitidine venetoclax. Some of these patients elected to come off therapy. And within that cohort of patients, the 2-year treatment-free remission was about 90%. So about 90% of patients stayed in remission if they become MRD negative with their NPM1 and they choose to come off therapy. Now, of course, retrospective, all the caveats, I have not yet incorporated this into my treatment recommendations, but patients obviously are very savvy. They know what's happening in the world and hear about things like treatment-free remission. So this is a conversation that I've had more and more with patients. And a motivated patient that is willing and able to have close surveillance for MRD, I kind of discussed risks and benefits. And if they become MRD negative at the end of several cycles of azaven with regards to NPM1, that's the only subset I've adopted this in, I'll at least talk about it and come to a shared decision about whether or not that's something we can employ. The tricky part, which Rohit, you may have been alluding to, is we don't know how well going back to azaven will work if and when someone's disease recurs. It's not like CML, where we know with great confidence that once someone needs to go back on a TKI, they can probably go back to the same TKI. So the worry is Aven may not be effective if and when there's recurrence or relapse of the disease.
We always continue to say that these are intensive induction ineligible patients. We all know that HMA, when combined with the Venetoclax, is not the easiest regimens to tolerate either. Cytopenias play a huge role, TLS, against monitoring these patients closely with antiviral, antibiotics, antifungals is a key aspect that one has to tie in. All right, moving along into our relapsed refractory space. Unfortunately, relapsed disease is rather far too common. For a relapsed refractory patient, Anand, importance of retesting for molecular profile and your treatment paradigm in these settings.
Yes, I would say reprofiling a patient at relapse or recurrence is a must. Our colleagues at MD Anderson looked at this and found that it was somewhere in the neighborhood of 30% or maybe even higher percent of patients acquired a potentially actionable molecular mutation at relapse or recurrence that they did not have at diagnosis. So common ones that can pop up, I would say, are FLT3 specifically. FLT3 can be present at a very low level at diagnosis. It may not even be picked up on your molecular sequencing up front. And then at relapse, it can become the dominant clone. That is an essential piece in reprofiling patients to see what, if any, targeted therapies are available. And thankfully, over the last several years, our playbook of targeted therapies has expanded quite a bit. We do have options to go to. Now, gilteritinib is FDA approved for both ITD and TKD. In real world data, it seems to have the same benefit whether someone has been naive or been exposed, which I think is very important. Quizartinib, there's data for its use in relapsed FLT3 ITD as a single agent as well. So it doesn't carry a label for that here in the United States. It does outside of the United States, but that's another option to consider. Although in general, our preference is to get gilteritinib if someone has not already seen it. In the space of IDH inhibitors, enasidenib and ivosidenib have been around for almost 10 years as approved therapies. It does seem that IDH mutated patients are sensitive to azacitidine and venetoclax. If there is a relapse or recurrence of disease, ENA and IVO don't seem to work quite as well in patients who are venetoclax exposed. Azacitidine, which is a newer IDH1 inhibitor approved in the relapse refractory setting, seems to maintain its efficacy to some extent in a ven-exposed patient. But again, small numbers, subgroup analyses of the studies that led to its approval. So we'll have to see how that story develops as we're trying to think about what is the best IDH inhibitor to use or IDH1 inhibitor to use for someone that hasn't seen one yet with a relapse of disease. And then lastly, in this targeted therapy bucket, we have revumenib. So revumenib is kind of the lead agent in a class of drugs, menin inhibitors, and there's several in development and in the pipeline. Revumenib currently is approved for relapse refractory KMT2A rearranged acute leukemia, both AML and ALL, with a positive phase 2 study in the NPM1 mutated space. And I believe it's going to be reviewed by the FDA this upcoming fall to see whether it's ultimately will receive approval for NPM1 mutated disease as well. So, a CR rate of around 20%. These CRs tend to be quite short. In transplant eligible patients, the goal is to try and get them to allogeneic transplant. Unfortunately, if you're transplant ineligible, if you achieve a remission, obviously that's a great step in the right direction. But how long that remission will last can be a few months or less, which makes it difficult. And I think that's what's led to a lot of interest in kind of what we were talking about earlier, moving targeted therapies from this relapse refractory setting to the upfront setting with the backbone of either intensive chemotherapy or HMA venetoclax.
Menin inhibitor story is exciting. We first covered this back in ASH conference highlights for 2023, and then it got approved. There are ongoing studies of moving this earlier and earlier. And I know I started off by saying that when it comes to AML, this is one of the most aggressive cancers that we see. But the matter of fact is the outcomes of AML differ drastically from months of overall survival for therapy-related leukemia to years when it comes to IDH and NPM1 positive disease. Anand, thank you so much for walking us through your treatment paradigm in treating acute myeloid leukemia. For our listeners, let's go over a quick recap from today's discussion. In today's episode with Dr. Anand Patel from University of Chicago, we focus on treatment algorithm for acute myeloid leukemia. The big emphasis throughout the discussion was on risk stratification and molecular profiling at the time of diagnosis, but this is also important at the time of relapse disease. Patient outcomes differ based on these findings, and we now also have several targeted agents, be it your FLT3 mutation, IDH mutation, or even your KMT2A alterations that we can go after?
For fit patients, standard induction 7+3, along with targeted agent, if there is, in fact, an actionable mutation present, still remains the standard of care, or rather CPX351, especially in therapy-related cases. If patients are unfit for intensive chemotherapy, we rely on hypomethylating agents with Venetoclax. Targeted agents play a big role here as well. Managing side effects, including cytopenia and infection, is critical. Thanks for tuning in. Make sure to check out our other discussions around challenging cases, treatment algorithms, and conference highlights. We are the Oncology Brothers.